Welcome back to our Meet the Professor series, where every couple weeks we sit down with a professor and pick their brains, followed by a live lecture from the professor we interview every other week. This week we have someone incredibly special, Professor Mike Edmonds. Most of you will know him, and a lot of you will have most likely referenced him in your papers. I know I absolutely have. Professor Mike Edmonds is a different guest than we normally have interviewed in the past, as he did his medical training at King's College, gained a fellowship in 1991. During his medical training, he developed a keen interest in diabetes, and more specifically, a keen interest in neuropathy in the diabetic foot. His interest led him to develop, unbeknownst to him at the time, the first MDT team that comprised of a doctor, a podiatrist, an orthotist, and a nurse. He'll be joining us today, where he talks us through his journey and his struggles and his accomplishments. Please help me in welcoming Professor Mike Edmonds. Hi, Professor. How are you doing today?
Hi, fine. Thanks for your kind invitation and your kind introduction. It's a great pleasure and honor to be here talking to you and going over the important things in diabetic foot care.
Absolutely. It's such a pleasure to have you here. So let's go back to the beginning. Why did you pick medicine as a profession?
I was interested in biology and history at school. So I had to plump for one, and I plumped for biology.
Right.
And that really took me on to medical school, basically. Although history and the history of science has also been very important as a useful sort of context.
No, why was it important to you?
I think we learn from mistakes of the past, and we can go forward, and we should always be trying to improve the situation of the humankind. And there was a lot of improvement that needed to be carried out in our people with diabetes and with foot problems.
Is that in reference to reducing the number of amputations that the diabetic patient goes through, or?
Yeah, particularly as it is well said that the 80% of amputations follow from an ulcer on the foot, and theoretically, those 80% of amputations are preventable, but they are not prevented. And why is that? And it really is quite a tragedy that people have to go through these life-changing operations when they perhaps could have been prevented. I need to state here, when a person with diabetes has an extensive problem and has reached a terminal stage with their foot and maybe in pain or maybe in severe infection, which is a risk to their life, of course, amputation is then a very good procedure and can relieve their pain and also save their lives. But my point is that we should do our best to prevent them getting to that stage, and thereby preventing what is then a necessary amputation. But if we had intervened earlier, then the person may not have got to that difficult stage. So I set about trying to improve the situation in persons with diabetes. And it really, I saw the benefit of the multidisciplinary team right from the start. As you mentioned, I trained at King's College Hospital, did my basic medical jobs, and then specialized in diabetes. From there, I got a fellowship to King's College Hospital to investigate blood flow in the neuropathic foot. But to do that, I had to have neuropathic feet without ulcers. And there were a lot of feet with ulcers. So we had to get them healed. At that time, in King's College Hospital, the diabetic feet were treated in two locations, one in the diabetic clinic and two in the podiatry clinic, which was then called, in the early 1980s, 70s, the chiropody clinic. So we tried to combine them, and the way we combined them was really the eureka thoughts of the then podiatrist at the time, Mary Blundell, who said, we're looking at people in two different places, why don't we look at them together in one place? And Mary invited me to her clinic. So we were able to start that clinic. It was May the 7th, 1981, Thursday. It was just then a Thursday morning. And we started with the orthotist and a nurse and Mary and myself, and an orthopedic surgeon came in a little later in the morning. So that made the multidisciplinary team. As you say, we called it a specialized clinic at that stage. And we were able to reduce the major amputations by 50% from 1981 to 1984. And we were able to produce a paper reflecting this in 1985, Improve Survival of the Diabetic Foot, the Role of a Specialized Foot Clinic. From there, this standard of 50% reduction in, well, it was in our case 3 years, was taken on, and it was taken on by the WHO and the International Diabetes Federation. And at that time, there was a concern and interest in the fate of people with diabetes, particularly their complications. And there was a meeting in 1989 in St. Vincent, which is an Italian town, attended by the International Diabetes Federation, the WHO, patients' societies, and they got together to make the St. Vincent Declaration, which was to improve the outlook of patients in the foot. They wanted 50% reduction in 5 years. They also set targets for the reduction in retinopathy and also improvement in the outlook of diabetic ladies who became pregnant and delivered and delivery of babies. So that was a landmark. It set the scene, as it were, for this 50% reduction. But going back to 1981 and subsequently, of course, you'll know from the mathematics that we've celebrated our 40th anniversary this year. And over the years, I've been really impressed by the gradually extending role of the podiatrist in that clinic. And I think these are very exciting times when this role will increase, and podiatrists have a great opportunity to make a great difference and improve the care of the person with diabetes. And just to mention this, early on, the podiatrist is the gatekeeper of the diabetic foot clinic, receives patients, assesses them patients, diagnoses the patients, and then in a sense will link in with the joint clinics, with the surgeons and the diabetologist, if necessary, to put forward the continual treatment of the patients. And within that, there's extended role. Our clinic at King's does all the plaster casts, the total contact casts, themselves. The podiatrists do that for the neuropathic foot ulcer. This was particularly promoted by a lady called Ali Foster, who was one of the successors to Mary Blundell, and has been carried on by Maureen Bates, who is at the moment the chief podiatrist in the foot clinic. So this was important, and now the extended rows of debridement, quite big debridements in the clinic, tenotomies, bone biopsies are also being considered. We also extended the role with the post of the diabetic foot practitioner. Now, this was a podiatrist who worked on the wards, who coordinated the care, similar to the clinic, but coordinated the care on the wards for diabetic patients. So linked in with diabetologists, orthopedic surgeons, vascular surgeons, did the bedside debridements, the casting, and this has been a great success for the patient, and also the foot practitioner themselves. It's a very satisfying role. And also not in the clinic or the hospital. I think there's an extended role also in the community. And I think we have seen this in the recent COVID pandemic, when care partially transferred from the hospital clinic to the community clinic and to the patient's home. And I think it was this link up. Of course, community care was supported by the hospital care, greater communication with WhatsApp mechanisms and other telehealth mechanisms, but it allowed really good care to continue in the community. And there have been recently figures published of the major amputation figures in England over the COVID times and compared with the 2 years beforehand. And in fact, on a national basis, the number of major amputations have not gone up. In fact, they have slightly diminished, albeit in the older age group. And there may be special reasons for that. But overall, there have not been an increase, which people feared. And I think that's because England has a really good framework of care between primary care and hospital care, which excelled itself in the COVID pandemic. So these are all the great opportunities for podiatry as we go forward into this decade.
That's fantastic. And it's really interesting to see that progression. And when you sit there and think about this eureka moment that you've had and how it snowballed into something bigger, do you ever sit back and think that, you know, it was going to end up the way that it has right now? Because we're so ingrained in MDT at the moment that kind of picturing it as anything else is a bit strange to me. And as students, we're very much ingrained and taught how to work with other specialists and other team members. But when you started the first MDT, did you get any pushback, or did you meet any resistance, anything you've struggled with?
In those days, these were the early 80s. It was much easier to do things. Mary Blundell said, "Let's see these people together. Come to my clinic, and we'll start it." So I did, and we started it, and we didn't have to provide a business plan or anything else. We just did it, and I didn't know where it was going to end up. And Mary Blundell was very observant, and what did I contribute to her care? Well, in particular, and she noted this, she had been working with her debridement in the clinic, but sometimes having difficulty in getting the ulcer healed because infection could not be completely eradicated. So I was adding the antibiotics when necessary, perhaps in a much quicker mode than before. And she said they're healing. Together with her debridement and my in inverted commas, but the antibiotics, that healed. So it was a team issue. Now we have got independent prescribing for podiatrists, so that perhaps not is absolutely necessary, but nevertheless, the role of the diabetologist is also important, I think, in diagnosis. And of course, there's a slightly political role. If you're seeing patients in the clinic and you feel they need admission, then as the doctor, I can put quite a lot of force into that admission, whereas perhaps in some times where the podiatrist maybe have to send down to casualty or so. So one added to that. And of course, there was the orthotist linking in, there was the nurse who was adding education, and of course, the surgeon who came to advise the orthopedic surgeon and the vascular surgeon. But one of the main aims, of course, is to treat the diabetic foot as early as possible before you need the surgical aspect of it. Also, I must admit, in those days, in the early 80s, the ischemic foot was not such a big entity. I think people were not surviving that long. This was in the age before statins as such, and antiplatelets. They weren't surviving. So 2/3 of our people were pure neuropaths. So it was a case of relieving pressure, debridement, and treating infection. And of course, looking out for the Charcot foot as well, which needs early diagnosis, and also with casting. There's so much that can be done in an early stage to try and prevent the complicated foot or the severely complicated foot. And that's why we're promoting a case of early diagnosis. And I'm a member of, I've worked with the IDEAL group, which is an acronym actually for IDEAL, for insight, diabetes, excellence, access, and learning. And it's a group of multidisciplinary people who are keen to improve the outlook in general for people with diabetes. And we've written a position paper, and also with the help of a person with diabetes, established an acronym, ACT Now. And that is standing for A is for accident, C is for change, T is for temperature change, N is for new pain, O is for oozing, and W is for wound. And this is to give confidence to people with diabetes and also to healthcare professionals to be able to recognize the warning signs that might lead to an amputation, the red flag signs, and to feel confident to seek specialized help in either the specialized community clinic or the hospital diabetic foot clinic. So, and it's rather like the ACT FAST acronym, which encourages people who've had strokes. The FAST, the face, and the arm and the speech, the S and T, time to do something, to stimulate people to act quickly, because as we know, the foot is a time sensitive situation, and time is tissue. And I often sort of give this rather sort of a colloquial comment that you can have an intact foot on Monday, and ulcer on a Tuesday, infection on a Wednesday, gangrene on a Thursday, and lose your leg on a Friday. And up to recently, that has defeated every healthcare system in the world. And because there's an amputation every 20 seconds throughout the world. But we're beginning now to get on top of this and reduce the amputation rate, although we've still got a long way to go. And talking about amputations, just also to mention, with the extended role of the podiatrist, has been the development of the specialized vascular podiatrist. That is the podiatrist who specializes in with expertise in the assessment of the ischemic foot, and manages quite a lot of the ischemic foot, diagnoses PAD or critical ischemia, and decides whether the patient needs to go to the vascular part of the MDT or to a vascular clinic. And there's another issue on the horizon, and that is because of the success, in inverted commas, of the multidisciplinary diabetic foot clinic, the vascular community want to extend the advantages to the non-diabetic ischemic patient, which is a great idea, but it has to be organized. But there again, the podiatrist can be a very important part of that setup. So I think we're going towards limb salvage clinics for both the diabetic patient and the non-diabetic patient. And I think the gatekeeper will still be the podiatrist. It's such an exciting role, and any podiatrists learning in students, I exhort them to take an interest in this, because the number of diabetes patients is increasing, the number of complications at the moment are increasing, and the podiatrist can play an extremely important role and make a great difference.
Yeah, I fully agree, and that's so well put, and it's so amazing that you were able to establish this MDT team, and it's skyrocketed to what it is today, because now we have allies within the healthcare system, whereas I imagine that probably was not the case early on. And I want to kind of backtrack to something you had said earlier. What's the critical first step that podiatrists can take in early diagnosis?
The most critical step is diagnosing infection, because it's essentially infection that destroys most diabetic feet. And this is not so simple as it sounds. Let me just say, there is an element of destruction that can be put forward by severe ischemia, okay? The critical ischemia, where there is lack of nutrition, lack of oxygen to the tissues, and that leads to tissue ischemia and death. So that is ischemia. But I would say the ratio is 4-to-1 infection to ischemia. And it's so important to diagnose infection. Now, we do have the classical signs, the local classical signs of heat and swelling and discharge and pain. But, and this is where the problem comes, where the podiatrist has to be a great detective, because I say superficially, these are the signs, but for these signs to be apparent, you need an intact nervous system and an intact vascular system. And these are the two elements which can be missing in the diabetic foot. So we say that you have to practice neuropathic medicine as such. It's a combination of terms. Neuropathic medicine, because you've got to look for the subtle signs: minimum discharge, the ulcer may stop healing, the granulation tissue might become friable as such, there may be tracking. These are not classical signs, but you've got to look for them because you may not have the classical signs. And secondly, you do not have the systemic signs. And this is so important, that you may not develop a fever, the patient, even though they may have a severe infection, and they may not put up their white count. And why? Because the message that the foot is infected is not getting to the brain to set up a fever, and is not getting to the bone marrow for the white cells to start multiplying and come out and be the army against the bacteria. And this is so important. I think it's probably the most important thing I'll say tonight, because it can be so deceptive. Oh, the patient hasn't got a temperature. The patient's white count is normal. It can be a big problem. And it's a double whammy, really. For the start, you need your temperature to go up to combat the infection. You need your white count to increase to attack the bacteria. So you're not getting that. And then your attendants are coming along and not taking particular notice of this and being deceived that this is not a serious problem. And this is very important. And you therefore have to be very skilled. And as I've just said, you've almost got to be a Sherlock Holmes, a detective, to look for these subtle signs for infection. And similarly, this is slightly different, but looking for a hot red swollen foot as a prelude or as the first part of a Charcot is also very important, because if you miss that, then the foot will disrupt. You will get subluxation, you will get a dislocation and a change in the foot shape, and that will lead to deformity, that will lead to ulceration, and that will lead to infection and gangrene. So early diagnosis, and it's the podiatrist who is switched on, who can be really switched on to this and can make that early diagnosis. And with the Charcot, the podiatrist can early on can treat themselves. You need an offloading, you need a cast, either removal cast or a total contact cast. For infection, you would need ideally antibiotics, and the independent prescribers can start that now, or you can link in with the foot team and with the podiatrists and with the diabetologists.
So how can podiatrists be better detectives? Like what steps can we take to be better detectives?
I think it's noting experience and looking out for these non-classical signs and to be aware of it, and to be aware of these. We call them myths. These myths of diabetic foot infection, that you always get swelling and heat and pain. You don't. It's a myth. You don't get a high fever or a white count. It's a myth. So you've got to be aware of that. But you've got to look, and also perhaps related to this is the consummate skill of podiatrists in removing callus. Now, most of the callus you remove will be a debriding of an ulcer, but where it's very impressive is where, as podiatrists, you almost act as water diviners, but you're actually acting as pus diviners. You know, I've seen podiatrists think, yeah, there's pus there somewhere, but you can't, it's not discharging. And they can then, go to the sole of the foot and lift up a callus or some hard skin. And then you can see this blob of pus appear, and the foot can then be drained, as it were. So A, it helps the diagnosis, and B, it helps the treatment. And I would say, in particular cases, it's the renal patient, the patient on dialysis who has very severe neuropathy, often very severe vascular disease, and may not show virtually any signs of infection. And yet I've seen our podiatrists divine the pus and get the pus out and make that diagnosis. So I think podiatrists have the advantage. Of course, if they get pus, that makes the diagnosis quickly, but it may not be always like that. It's just picking out, as I said, these other signs, friable granulation tissue, and say tracking of the skin.
Right. Okay. So, I mean, from what I gleaned from that is that you have to look at the patient as a whole, as opposed to.
Oh yeah. But that there's another catch in that, actually, in the sense that because the nerves are not taking danger signals back from the foot to the brain, often the person with diabetes and a foot infection will be quite well. And eventually, and this is the sort of scenario, the patient will be sat up on the couch or in the bed reading the paper. Oh, the patient is well, in inverted commas. But very quickly after that, the patient may crash, suddenly may go down. So you've got to look at that. And also, I would remind you about the speed that I've talked about. And I always remember a case, a patient who came at 9 o'clock to the clinic and had an ulcer and a little bit of cellulitis. And we said, we're doing blood tests. We said, we really think you ought to come in. He was not keen to come in, but we started the investigation. And by 11:30, he was really ill. He was nauseated, he was vomiting, and he had a streptococcal infection. So be aware of streptococcal infection. And here is another catch. We always think that it's group A streptococcus which causes this flesh-eating disease. But in a person with diabetes, it can be a group B, particularly a group B strep or a group D strep or a group E strep. So you've got to know your microbiology. So I would advise podiatrists to really concentrate on the microbiology, because it's not simple. We're not dealing with one organism. We're dealing with polymicrobial organisms, and some bacteria may be commensal. So you've got to decide which is significant, which is not significant, and that's often very, very, very difficult. Microbiologists may have their own thoughts on what can be a commensal and what is not a commensal, but it's really quite confusing. But I think podiatrists, with their extended role of prescribing, will have to be aware of this and make these decisions.
Yeah. And that's really good that you mentioned advice. I was going to ask you what, before I let you go today, what advice do you have for students?
Yeah. Well, I think basically what I really want to say is be enthusiastic and don't be put off, and keep your morale up. Um, you may think this is rather paradoxical, but just to say that when we wrote up our first paper on the role of the specialized foot clinic, and it has been cited, quite a few times, but as such, but it was rejected by the first journal that we sent it to, rejected out of hand, and we then sent it to the Quarterly Journal of Medicine, and it was accepted. So don't be put off by what you feel are major setbacks. You've just got to keep going. I mean, peer review is okay, it's good, but it's not perfect. And your paper may not be rejected because of the intrinsic value of the paper. Many other things come into the equation. So I think you have to keep your enthusiasm going. The academic career, or clinical academic career, can be part of the ups and downs. It's difficult sometimes to get grants. David Armstrong has commented that in an article actually in Diabetes Care, there's a great disparity between the funding of diabetic foot research and the cost of care of the diabetic research. When I started, though, diabetic foot was a Cinderella specialty as such. I think that's improved now, and it's regarded as important. But I would say to your students, there is still a lot of clinical work to be improved upon, and there's also quite a lot of research to be done. I mean, I've been spending 40 years trying to work out the cause of the Charcot foot, and I haven't got there yet. I probably won't do. But so if any of your students need a project, they can look into the Charcot foot, and also in perhaps a little bit more of a down-to-earth issue, the amputation rate in England has not changed over the last 7 to 8 years. It hasn't gone up, but it hasn't gone down. And there's still quite a lot of work to be done. It's major amputations, about 7,000-8,000 every 3 years. So when we think that 80%, so I come back to my initial point, when we think that 80% of those are preventable, but are not being prevented, it's really quite a sad occasion. But I don't want to finish on a down note. Actually, just to say that research is very exciting, and you get the thrill of the chase, actually. And just to reiterate that, people watching tonight, as podiatrists, you can make a massive difference in the diabetes world and the diabetic foot world.
That's fantastic. Thank you so much for joining us today, Professor Mike Edmonds. Please join us next week for Professor Edmonds' live lecture, and it will be Tuesday at 8 p.m. and we will see you then. Thank you so much. Good evening.
Goodbye.